So now I have the pleasure of introducing a Norwegian speaker, Didrik Heggdal, a specialist in clinical psychology working at Vestre Viken. He has been developing the treatment model Basal Exposure Therapy, and that is what you are going to tell us about. Welcome.
Yes. Does it sound okay? Yes. I'm going to talk about this treatment model or modality. We have a treatment program in a locked ward based on this treatment model, and I'm going to tell you about the basic principles in treatment in this locked door setting. We have implementation takes a long time, and we have been working with this BET model for about 18 years. 10 years ago, the average treatment time was between 1 year and 1.5 years. Today, it's less than 6 months. So it takes time. I'm not going to talk about the program itself, but the program is for the patients. The program is a full-time work day from 9 a.m. to 4:30 p.m. Okay. And today it's about suicidality. And suicidality challenges us. And suicide prevention is a challenging task. It is not likely that we ever will be able to realize the zero vision that was put forward by the Norwegian Prime Minister some time ago, probably as a part of an international trend. Still, one of the main tasks in mental health care is to secure life and health of the citizens. What I'm going to tell you here today may be provoking. However, over the years we have achieved some very promising results. It seems that what we do somehow works. So before I start, I'll ask you, bear with me and stay with me. I'll try to describe how BET may contribute to the challenging task of suicide prevention. I'm not going to talk about suicidal patients in general, but focus on some of the most marginalized chronic suicidal patients in mental health care. And these patients are, in a mental health care perspective, they have severe and complex mental disorders. Their psychosocial functioning is severely impaired. GAF scores below 35. That means that they have a severe mental disorder, and below 30, which several of our patients have, then they also have severe behavioral disturbances and should be on a locked ward. They have histories of excessive self-harm and repetitive suicide attempts. And polypharmacy, the use of a cocktail of various medications. That might be antipsychotic medication, mood stabilizer, tranquilizers, antidepressants, and so on. And the patients, when the patient is admitted in the BET program, it should be more than 2 years since first hospitalization. Common to the group is that despite long-term cost-intensive treatment efforts, they don't get better or they even get worse. And the focus today is on self-harm and suicide attempts. And these patients, they are obviously suicidal. However, in BET, we never talk about suicide. Why is that? In about half an hour, I'll recapitulate the presentation and give you the answer to this question. But before we continue, you should note the following. It is, of course, not true that we never talk about suicide. We are committed to assess suicide risk. At admission and discharge, we ask the patient, do you have suicidal thoughts or plans? In between enrollment and discharge, the focus is on treatment. During the treatment, risk factors are continuously monitored and suicide risk is regularly assessed. But this is done without asking the patient, without talking with the patient about suicidality. The focus of the therapist and the team is on distressing thoughts and feelings. The patient may, of course, talk about suicide. The helpers still keep their focus on thoughts and feelings, and not on what the patient have done or might be inclined to do. We don't suggest that therapists in general should refrain from talking about suicide. What may be useful depends on the context in which what we do takes place. In the context of BET treatment, it seems that not to talk about suicide makes the treatment more effective. In other treatment contexts, this may, of course, be different. The best way to prevent suicide is to provide good treatment. This was said by a dear colleague of mine, Inge Brorson, who is sitting here on the first row, many years ago. It was very important to me. And Inge's support has meant a lot to BET. Inge has worked a lot with suicide prevention and trained health professionals to prevent suicide. And this treatment modality has over the last few years become an influential clinical practice and research project in Vestre Viken Hospital Trust. Today I'll talk about this approach, how this approach may lead to lasting improved and stable psychosocial functioning, and how suicidal behavior in this process may be reduced and extinguished. How are we supposed to help our patients? To me, this Chinese proverb illustrates a serious problem in the mental health care services. It says, give a man a fish and you feed him for a day. Teach a man to fish and you feed him for a lifetime. The patients who are admitted to BET have not profited from prior treatment efforts. What's more, they are marginalized and stuck in learned helplessness, and they have become dependent on the helpers. Our mandate in BET is to do something else. That is to refrain from doing more of the same that doesn't work. Therefore, we don't serve fish. Our task is to teach the patients to fish. Some patients really want to die. Other patients cannot stand their lives. But their wish is to live. They need change, but they are out of options. To commit suicide is the only option they have left. In mental health care, these patients are labeled chronic suicidal patients. They may talk with us about their suicidality and show us by their actions that they are desperate. But what is the message? There is something behind the suicidality that's feeding this behavior. Often the patients do not themselves know what that is before it is explored. It's something scary, something terrible. It's typical for the low-functioning patient that this emotional state is an undifferentiated psychological pain. The layers of emotions may differ from patient to patient, but this is what we typically see. Sadness, mourning, shame, existential loneliness, hopelessness, and existential catastrophe anxiety. We always find this as the inner core in the condition, some form of existential catastrophe anxiety. This is experienced as an impending fear of falling apart, dissolving, or being stuck in unbearable internal pain. This fear is the phobic object, the patient's basal phobia, the target for what we in BET call basal exposure. National guidelines on suicide prevention says that when we treat chronic suicidal patients, the patients, their families, and healthcare providers must expect a continued elevated risk for suicidal behaviors. The patient shall not be subjected to regulatory measures that may weaken the prognosis in long term. That means we should refrain from imposing regulation and control. If we become preoccupied with making precautions and try to protect the patient from himself or herself, we may limit the possibilities for recovery and autonomy. Considering these patients' history of self-destructive behaviors, fatal accidents may happen, even if the patient has no intention to die. The implication is that we as healthcare workers must deal with our own worries and our own fears, and not at least help the patient's relatives to handle their worries and their fears in a way that serves the process towards autonomy for the patient. In BET, we follow these guidelines. That is, we don't regulate and control the patients. And how does that sound? We don't talk about suicide, and we don't regulate and control the patients. I'll soon get back to how we do this within the context of a locked hospital ward. First, some results related to suicidal behavior. These data are from a retrospective study that we did last year. In the study, we compared number of hospitalizations associated with deliberate self-harm in both somatic and psychiatric hospitals 1 year before BET versus 1 year after BET. In the group, number of hospitalizations decreased from 123 to 47. That's a reduction of 62%. The number of patients hospitalized because of deliberate self-harm was reduced from 22 in the sample to 12. That's a 45% reduction. And reduction of hospitalizations was also associated with reduced experiential avoidance. The avoidance of inner unpleasant thoughts and feelings. It was measured with the AAQ, Acceptance and Action Questionnaire. So the AAQ scores was reduced from admission to discharge, and low AAQ scores at discharge was associated with reduced hospitalization. And here's the data from another study, indicating significant improvement from enrollment to discharge as measured by global assessment of functioning. When the patients were discharged, they still had distressing symptoms. We see a reduction or improvement of scores from somewhere above 30 to somewhere between 45 and 50. They still had distressing symptoms, and most of them were still not able to work or study. A new follow-up study, not yet published, indicates that a significant proportion of the patients 2 years after discharge have achieved recovery, which means work or studies full-time or part-time, a stable life situation. And in addition, 40% of the patients were off medication. Over the years, we have systematically worked to reduce the level of external control in the BET treatment. Here we see from the period 2006 to 2008 to 2012 to 2014, The average percent of the treatment time in voluntary hospitalized was reduced from 60 to 17. To change a whole team's way of functioning takes time. It's not only about a new way of understanding mental disorders and how to learn new practical therapeutic skills. Implementation of a comprehensive treatment modality requires a cultural change, which may mean a profound change of values and attitudes. And in the case of BET, a fundamental switch from control and symptom reduction to emphasis on collaboration and autonomy. Here we see the reduction in use of coercive measures. Today, we rarely use mechanical or physical restraints, that is, almost never, and we never use forced medication. In mental health care, many say that to reduce the use of force, you have to use more medication. And then look at this. In parallel with the reduction of force in treatment, the use of medication at the BET unit was significantly reduced. As compared with the average of the other units at the hospital, we have reduced the use of medication with about 60%. So how do we do this? First, we have to define the problem. The definition of the problem identifies the mechanisms we should try to modify. The general BET case formulation is just one perspective among many possible ways to understand the patient's condition and situation. However, this perspective seems to be useful considering the typical treatment histories of the BET patients. If we look at this model here, all treatment should ideally progress from dependency towards autonomy. All kinds of treatments. And we may say there are two dimensions in treatment. First, intervention that regulates symptoms and behavior, and interventions that promote self-regulation. The general idea in mental health care is that if we regulate symptoms and behavior, we make people better, which also may include making them less suicidal. In clinical practice, first we regulate, then we promote self-regulation. Or by regulating the patient will be enabled to self-regulate. This may be useful and applied to some patients, but not to the best patient. This is what happens. The BET patient uses coping strategies that may be effective in short term. And the healthcare workers do the same. They use treatment strategies to stabilize the patient, which may be effective in short term. We may say that both patient and helpers engage in problem-solving strategies aiming at control. The patient tries to control his pain, and the helpers try to control the patient. Thus, they get stuck in a vicious circle, a positive feedback loop that lead to marginalization. And contrary to what's the intention, the helpers undermine progress towards autonomy. The aim of BET is to stop this marginalizing interaction and mobilize the patient's resources. So how do we do that? Yeah, treatment stops. The answer at this stage is complementary external regulation. SER. SER is both a therapeutic stance and a comprehensive treatment strategy. We may say that SER is the contextual platform from which the total body of BET interventions are administered 24/7. As we saw on the previous slide, commercial treatment intervention is usually adapted to the patient's level of functioning to keep him or her stable. That's where the marginalizing marginalizing interaction is going on. In bed, we don't do that. We under-regulate the patient. Well, traditional treatment keep the patient stable here and get stuck in a positive feedback loop. We don't impose control. This is what we call under-regulation. The patient, of course, he becomes unstable. There is nothing to support him or her. And she may get into trouble. She may hurt herself 1 time, 2 times, but suddenly she mobilizes resources to stabilize herself, to self-regulate. Sometimes, not often, but sometimes, the patient is so regressive that he or she does not mobilize the resources. Then we switch to what we call over-regulation. And this regime is adapted to the patient's attachment strategies. Here we have a strict focus on securing life and health. The patient using A strategies, that's the introvert patient who cuts contact with the feelings. They get overstimulated. They withdraw from relationships. Then we have the patient in this situation, and we talk. We talk about her, about life, everything. We stimulate her. The C patient is the dysregulated patient, the restless, agitated patient. They are understimulated. We get slow. We are always friendly, always respectful, but we put them in a situation they don't want to be in. It's not comfortable. And they want out of this situation where we focus on securing life and health, and they get motivated for making new efforts. And then we go back there. There's not one step at a time. When we under-regulate, we use validation. It's a primarily therapeutic tool, and solution-focused interventions to reinforce functional behavior. Over-regulation is rarely used. Actually, we have used it once during the last 4 years. Under-regulation is almost always sufficient to mobilize the patient's resources and facilitate motivation and to collaborate about treatment aiming at autonomy. By SER, complementary external regulation, interaction is normalized and behavioral disturbances at the ward are more or less eliminated. For the individual patient, this is the first step towards a therapeutic relationship and a working alliance. The next step is to establish a sufficiently solid and stable working alliance. And first, we talk matter of fact. And before I continue, I should emphasize BET is founded in and guided by a set of values that should be reflected in all we do and all interventions. These values are empathy, respect, and equality. Another thing that should be mentioned is WHO's definition of health. This definition says that health is the absence of pain. The definition is absurd. If you buy this definition, you will sooner or later get into trouble. And as guided by this definition, mental health care is in serious trouble, not at least when it comes to the BET patients. So we talk matter of fact to get our feet down on the ground. Life is painful, and life will continue to be painful. First-order strategies doesn't work. First-order strategies is to fix, remove, reduce. All attempts to remove pain have proven to be futile. By avoiding pain, you maintain your problem. Suicide is an option for all of us all the time. We can choose life, or we can choose the emergency as exit, death. Beth invites the patient to switch from first-order to second-order strategies, change strategies. You can solve your problem by choosing not to avoid. The solution is to relate to pain as part of life. This is best presented as a psychotherapeutic model. Complementary external regulation is the contextual platform from which BET is administered as a psychotherapy. STER is used to reduce behavioral disturbances and normalize the interaction between patient and healthcare workers. Then we can concentrate on the psychotherapeutic work instead of spending all time and energy on handle acute situations. And second, the working alliance. Through psychoeducation, the patient realizes that if he wants change, he has to assume responsibility for this problem. You avoid, that's why you have problems. It lies implicit in the BET model. The patient avoidance behavior creates and maintains his problems. When the patient and the therapist reach an agreement on how to understand the problem and how to solve the problem, the working alliance is established. During the next phase, the patient and therapist collaborate in exploration of avoidant behaviors and typical patterns of avoidant responses. If you don't know how you avoid, you will not be able to choose to do something else. The patient's avoidance have become automatized. When you're aware of what you do when you avoid, you can alternatively choose not to avoid. That is exposure. And then there the patient had the responsibility for the solution, to choose exposure. The patient is responsible for the problem and now also responsible for the solution. After some time in treatment, the patient will start to self-expose. That is, use exposure or second-order change strategies without health professionals present. When this happens, when the patient uses self-exposure, this skill is consolidated by the use of solution-focused interventions. We focus on what the patient does that function, and now we talk about second-order strategies, and continue to defocus dysfunctional behavior. Still no control. And at last, most important, solution-focused interventions make the patient responsible for success. Being responsible for success feeds the patient's self-esteem, and the consolidating solution-focused intervention is in BET assumed to be an important factor that promotes lasting improvement of functioning. The disillusioned and helpless BET patients will usually not cooperate and engage in discussing alternative solutions with the therapist. To prime these patients for change and resource mobilization, it seems essential to refrain from using regulating and controlling measures. This way of working with suicide prevention means that we have to see the chronic suicidal patient as responsible for their own lives. And here I have to repeat myself. This will work. This will not work if what we do is not founded in empathy, respect, equality, and compassion. Recapitulation. Why the bed therapists never talk about suicide? Severely traumatized and marginalized people have suicidal thoughts, more or less all the time. For some patients, focus on suicidality and external control may maintain and reinforce suicidal behavior rather than reduce such behaviors. In such cases, as with the bed patients, treatment should not focus on the behavior itself, but instead target the inner experiences that are feeding suicidal behavior. In bed, the promotion of acceptance and unwanted private events seem to reduce and extinguish suicidal behavior. But always remember, in an acute situation, external control may be a necessary short-term solution. So far, 70 patients have been treated in the BET program, and so far, none of the patients have committed suicide. Here's a quotation from a qualitative study we did some years ago. The quotation reflects how the patient may experience the BET process. This former patient was for a period of 8 years more inside the hospital than outside. She's now married, has a little baby, and she works in a kindergarten. From being a person who didn't function at all and then enabled to deal with life is more than I ever thought I could achieve. I have found back to myself, to who I was before I became ill. Some days can be hard. I feel down and want to stay in bed, get angry and start to cry. The suicidal thoughts, self-harm and hospitalization belongs to the past. It's like being in a different world. I realize more than before how I react and act. I used to feel worthless, being a psychiatric inpatient who year after year was tossed back and forth from one hospital ward to another. Now I'm able to be on my own and cope. That's really the biggest change. I have a life. So the bottom line is, teach the patient how to cope with life, and he will spend his time living it. That's BET and suicide prevention. That's it.